Welcome, everyone, to our last Let's Talk event of the year. And we are starting again, I think next date will be in February or March. But this is our last Let's Talk of the year. I'm Judy Regensteiner. I'm the director of the Center for Women's Health Research. And I'm really thrilled to see you all here tonight. We have many people who have been to many programs. We also have many friends of the center and many members of our advisory board here tonight, and I'm thrilled to see all of you. Thank you for coming. We have a very exciting program tonight, just a little bit different. We're going to talk about some things that don't get discussed as much. We're going to talk about dermatology. We're going to talk about different parts of the body than we often discuss, and we're going to talk about orthopedic surgery, which probably you do hear more about, but we have the best speaker on that topic anywhere. And all of our speakers are excellent. I'm really thrilled with the lineup we have tonight. The mission of the center is to do cutting-edge research in women's health and sex differences with particular focus on cardiovascular disease, diabetes, and mental health as it intersects with physical health. Those are our three major areas. We have 70 young scientists now doing this work, and that's related to the second goal of the center. Second part of our mission is to educate and train and fund the next generation of researchers in women's health and sex differences. And as I mentioned, we now have 70 young scientists that are funded by the center, including about 3/4 of them are female, 1/4 of them are men, because we want men and women to study women's health. That's how you really grow a field. And that's our role here, is to grow the workforce for women's health and sex differences. The third part of our mission is to educate the public and healthcare providers, and it's with that in mind that we hold our events for the public and healthcare providers. And this event is for the public, as you all know, and we're really thrilled again to see you here. Our first speaker tonight is Dr. Sabrina Newman. Dr. Newman received her MD degree from Georgetown University. She's assistant professor of dermatology and director of inpatient dermatology consult service and co-director of the multidisciplinary rheumatology dermatology clinic. She also leads the telemedicine initiative for the Department of Dermatology and is committed to improving timely access to dermatologic care, which I really appreciate, as does everybody who seeks dermatologic care. Her clinical focus is on complex medical dermatology. I will welcome Dr. Newman to the podium.
Thank you. Thank you for that introduction. Okay, so thanks for having me here. For the next 20 or so minutes, I'm going to be talking to you about fact or fiction with regard to the skin. It's going to be a little bit of a rapid fire. So a couple of facts, quick facts about the skin. It's the largest organ, which some of us don't think about. 1 in 4 Americans actually are dealing with some form of skin disease. And then half of those are actually over the age of 65. Also, skin diseases here in the United States actually cost the U.S. healthcare system quite a lot of money. So 20 facts in 20 minutes is what we're going to do. So it's going to be a bit of a rapid fire for us. But my whole goal actually is to arm you with some really important information about the skin that you can bring back to family and friends. But more importantly, we want to debunk some myths, a lot of which are deep-rooted in the internet and also sometimes in the media. So we're going to get started. Please feel free to participate. Raise your hand, call out, because we are going to be going through a bunch of questions. So we're going to start with the sun and your skin first. So 1 in 5 Americans will get skin cancer. Is that fact or fiction? Fact. Okay, great. Yes, so 1 in 5 Americans would get skin cancer. And when I talk about skin cancer, I'm talking about basal cell skin cancers, squamous cell skin cancers, and then melanoma. And unfortunately, 20 Americans actually die every day of melanoma in this country. So you need UV or ultraviolet exposure to get enough vitamin D. Fact or fiction? Fiction. So you do not need ultraviolet exposure to get enough vitamin D. Actually, the United States Department of Health and Human Services and the World Health Organization determines that ultraviolet light is a carcinogen, so it means it can cause cancer. So it's actually not recommending that we get our vitamin D from the sun. More importantly, they're asking us to get it actually from diet. So all of the recommended amount of vitamin D is actually based on consumption within our diet and not has anything to do with related to getting it from sun exposure. In particular, our skin is actually pretty, it can be efficient at creating some vitamin D, but it's very inconsistent in doing it. Okay, So one blistering sunburn during childhood or adolescence may double your chances of developing melanoma. Fact, yes. So it only takes one blistering burn as a kid, which is why really early on we want children to be protected early on, not so much for them to also get into a good routine and behavioral style of staying covered in the sun, but really it doesn't take very many sunburns. I like this picture a little bit. She does have sunglasses on. She's getting a little bit of sunscreen, but I would much rather prefer children look like this at the beach. And this is the way my children look at the beach or at the pool. So if you see any little kid running around like this, it's probably Dr. Newman's child. But this actually does provide a lot of sun protection. So we're talking wide brim hats or hats with the flap, and then full coverage. And these are now readily available and actually can be quite inexpensive as well. So protecting our children is really important early on. Tanning beds are safer than the sun. Fiction. There is actually, it's a lot of interesting data, but the United States, I think it was the House of Representatives, actually did a study. They called a bunch of tanning salons, and 90% of them actually told them that tanning is safe and actually has a lot of health benefits. And there is some information, if you look on the internet, that actually says tanning is safe. And so there's really no such thing as safe tanning. A tan is actually a way that your body is protecting itself from damage. So any tan is that. Sun is a carcinogen, so when we create a tan, it's because your body's saying, hey, I need to try and protect myself, so it makes more pigment. It also thickens the first layer of the skin just a bit to also provide, to try and do that. So a tan can protect you from sunburns. Fiction, so it's this whole idea that if I get a base tan before I go on my Hawaii vacation, I'm not gonna get sunburn. And I hear this actually still quite a bit, that a base tan is going to prevent them from sunburn. Absolutely not true. A base tan is actually the equivalent of an SPF of 3, which is pretty much 0. But also more importantly, most folks are going to tanning salons to obtain these base tans. So base tans do not protect you from sunburns. This is a free fact. Women between the ages of 25 and 29, actually melanoma is the most common cancer. And luckily, that actually number over the last 10 years is going down a bit. And we believe that is from a lot of health promotion and sun protection. But that number was high partly because of tanning. So that's what it's been attributed to. It's really nice to see that number going down, but we have a lot of work to do. And this is why I mentioned this. Here in Colorado, we actually have no tanning bed regulation or restrictions, which means if you have a 6-year-old and you want to bring them to a tanning salon, you are allowed. And because we know, again, one blistering sunburn can double your risk of melanoma, this is something we probably should work towards. Next, can skin cancer be prevented? Fact, skin cancer actually can be prevented. The vast, vast majority of skin cancers, in particular basal cells and squamous cells, which are directly due to ultraviolet B radiation, so that's sun exposure, sunburns, and cumulative sun exposure, actually is prevented, and the vast majority of melanoma also actually can be prevented. So when I talk about skin cancer prevention, it really is not just about sunscreen. It's about seeking shade, trying to avoid high peak sun, so 10 to 2 p.m. Sun protective clothing, that's a big push I like. Wide-brimmed hats, long sleeves. There's a huge market now with a lot of UPF clothing, but what I'd like to say is that actually run-of-your-mill clothes actually is very effective at blocking UV rays. The only one that isn't is something white t-shirt or white cotton based. So if you have a long sleeve t-shirt, dark in color, you're actually getting yourself some extra sun protection. Again, get vitamin D safely. That would be through foods and or supplements if you need to. And then in particular here, snow, sand, water, you really want to be careful because that ultraviolet radiation. And in particular for Colorado, we're at a higher elevation, so actually our UV index is much, much higher than in some other places. Okay, melanoma strikes men harder. It's actually a fact. So men are actually more likely to die from melanoma than women are. One of those reasons why potentially could be the way men's skin actually differs from women. Men tend to have more collagen, which is a building block of their skin. They have more elastin, and they actually have less fat. So they think that that's partly why this could be the case. Another is that actually they've done surveys, and men are less aware of skin cancer risk, and then are less likely to be sun protective strategies. Okay, so women who are under 40 have higher rates of basal cell skin cancer compared to men. So that's a fact, and that's actually because of tanning. So under the age of 40, basal cell is what we call our non-melanoma skin cancer. It is slow growing, but can cause some local damage, so it does need to be treated. But early on, this was someone who was on the news, but she was diagnosed in her early 20s with a basal cell, and because of tanning. So let's talk about sunscreen. This past summer, there was a lot in the news about sunscreen that I actually found very confusing myself, even as a dermatologist. So I do want to go through some of this and get some facts about sunscreen and safety. So first, let's go. I don't need sunscreen because my makeup has sunscreen. Fiction. So if you were to put 14 to 15 times the amount of makeup on, you would get the amount of SPF in your makeup. But it's not the only sunscreen that you should be using. So you should wear sunscreen first, and then you can apply your makeup with some SPF in it on top of it. But certainly don't rely on your makeup to help protect you. Okay, you don't need sunscreen on a cloudy day. Fiction, yes. My son loves this because he loves to tell his camp counselors how much he needs to reapply his sunscreen even if it's a cloudy day. So I'm very happy, I'm very excited when he tells me these stories. So 80% of UV rays actually penetrates clouds. So it doesn't matter if it's sunny or cloudy, you still need the same amount of sunscreen. Okay, so the FDA is saying sunscreen ingredients are unsafe. Got a little bit more murmuring here. So that's fiction. The FDA is actually not saying that sunscreen is unsafe. It's saying that they need more data. And so with the recent report over the summer where they talked about a study that came out of one of the big medical journals, part of the FDA and some other researchers looked at 24 volunteers putting on lots of sunscreen, so certainly more than most folks will put on, 4 times a day for 4 days straight. Now that could certainly mimic if you were at a beach or on a holiday, that would be the amount of sunscreen that you're putting on. But there's a lot more. So they found that there was sunscreen absorbed. And so then the question is, well, if it's absorbed, is it safe? And that's what the FDA is saying, that we need more data. So the FDA is recommending the public not to use sunscreen until there's more data. Right, so that's fiction. It's not saying that. It actually came out specifically saying, no, we know ultraviolet causes cancer. We need more data on some information, but please continue to wear sunscreen. And again, when I say sun protection, it really is not just sunscreen. So we want you to have sun protective clothing, and it's really that combination. But again, we're looking for more data. So what is FDA proposed rules actually saying? They also came out with certain rules, and I wanted to share these with you because I still find, if we're learning that we're absorbing all of these chemicals, really could they be safe for us? We really don't know, but if you have any hesitation, I would not recommend not wearing sunscreen. What I would recommend is using something with zinc or titanium. So those are barrier protectors. Also, the FDA has regarded those as safe and effective sunscreens. So if you have any concern, just turn to something that has zinc and or titanium in it, and you'll get that help. There's 2 ingredients that they mentioned that are certainly not safe to use. Luckily, we do not use those in the US in any of our products. And then the 12 more common sunscreens is what they're looking for more data. I like this picture for 2 reasons. One, it's a man, and we want to make sure that men are also staying protected the same way we would as women. But also, it's skin of color. Even in those with skin of color are still at risk for skin cancer and all types of skin cancer. So sunscreen, all the sun protective strategies fall through for everyone. So let's go on to aging in our skin. Some good news, maybe some bad news. So acne is only for teenagers. Yes, I see a lot of oomph with that. Yes, so unfortunately, although commercials will elude you to believe that acne is only a teenage disease. It's absolutely not. We see lots of acne at all ages, particularly over the age of 40, which tends to be a little bit more of adult acne. What I want to mention about this, when we're older, we have to be careful because actually our skin can get irritated to some of the over-the-counter acne medications. So we actually treat acne, adult acne in particular, actually differently than we would teenage acne. So just be careful. Using harsh products, over-drying your skin actually can worsen acne. So greasy foods can cause acne. Fiction. So greasy foods or junk foods do not cause acne. So there's been no data to suggest that bad food for us causes acne. What I will tell you is we know foods with high glycemic index, so those are refined breads, flours, rice, actually has been associated more recently with contributing to acne, not necessarily causing, but contributing to it. Milk, particularly skim milk, also has been linked in a few recent studies with worsening of acne. That partly is because skim milk has a higher glycemic index than whole milk does. So it's not necessarily the milk, but rather the glycemic index of it. And then things that do help with acne, green tea, broccoli, fish and high in omega-3, and also I have on there zinc. So zinc is actually a supplement that can be very helpful for the skin, in particularly for acne. Okay, so sunscreen is the most effective way of preventing wrinkles. Yes, and the reason why I mention this is because when I see a lot of folks in my office from at any age, young and old, they always ask, how do I prevent wrinkles? And really, it's sunscreen. So the sooner you use it more consistently, the better. And this is daily sunscreen, particularly here in Colorado, because just being in your car, we actually get a lot of sun through the windows, not our windshield, but actually the side windows. So UVA, which is that deeper penetrating sun rays, the one that actually causes melanoma, actually comes through our passenger and driver's side window. So even if you're just going to be commuting to work and commuting home, sunscreen is actually still important to have. It's not just the day you go out hiking. I like this little skit on what's leather, leather skin, and how do you make leather? You tan it. So don't tan your skin if you don't want leathery skin. So falling estrogen levels contributes to skin bruising. That is a fact. So we actually see a lot of this. Partly when estrogen falls, our skin thins. And when our skin thins, it's just more prone to trauma. And those really tiny blood vessels high up in our skin are just more prone to rupturing. So dry skin worsens after menopause. Yeah, unfortunately. So it does. Dry skin is worsens after menopause. So the older we get, the less efficient our skin is to holding on to moisture. So our job actually is to make sure we're creating a good barrier protector. So moisturizing within 2 or 3 minutes of coming out of the bath or shower, using a thick moisturizer, so something that's going to lock in the moisture. Things like coconut oil and safflower oil actually have been found very effective as hydrating for the skin. So if you're looking for natural things and not wanting to put on other creams, they're actually very, very effective. Mild soaps, so we actually want to avoid soaps altogether, particularly detergent soaps, and use more cleansers on our skin. So something like Dove bar soap has a pH of 7, which means neutral, so it doesn't strip the skin of the oils that it needs to hold on to moisture. Potentially humidifier during the winter can be a little bit helpful, and some data to suggest that some essential fatty acids actually, like fish and omega-3, can be helpful too to your skin in being able to hold on to moisture. So women are more likely than men to develop rashes after the age of 50. True, that's actually a fact. The reason being is that the pH of our skin changes as we age. So normally we want it to be more acidic, and then as we age it becomes more basic. And as a result, unfortunately, we're more prone to skin irritation and sensitivity. So then we're more prone to itching, and itching causes rash, and that's how we get into that cycle. And so it is important, again, bland products can be very helpful, and maintaining that skin barrier can actually protect your skin from being irritated. So briefly, I'm going to go over some medication and your skin. So nearly 10% of women undergoing chemotherapy for breast cancer considered avoiding treatment due to hair loss, and this means avoiding treatment altogether. Fact or fiction? It's actually a fact. So up to 10% actually considered not even going through with chemotherapy because they were worried about hair loss. And I wanted to mention this for a couple reasons. One is there are things we can do to help minimize hair loss. But two, I think it's important that it's okay to be worried about hair loss. This is actually, I'm pretty passionate about chemotherapy and medications, changes on the skin. I have an oncodermatology clinic where it focuses on treating patients with skin reactions, hair, nails related to chemotherapy. And I have a lot of women who come to me and say, I know I should just be grateful that I'm getting treatment. And they feel as though they can't complain because they're doing well on treatment, but they're having all these terrible side effects. And I just want to make a point that it's actually very important for me, for you as a patient, that we handle all the side effects that are going to come with any treatment. So whether it's cancer or whether it's high blood pressure or diabetes, that we can actually help with that. And so, you know, it's disheartening when women don't want to come forward because they feel as though they're being vain, and that's exactly the word I hear over and over again. So just don't be afraid to seek help. We're here to help. And then this is something I want to spend my last amount of time on is if it's natural, it must be safe. Fiction. And I'll go through this little infographic because I thought it was really interesting. Over the last 10 years, actually, there's been a significant increase in contact dermatitis, so that means sort of itchy rashes that you've become allergic to. That's been correlated with increased use of essential oils. No, it's not to say that essential oils should not be used, but it's just to say that just because it's natural doesn't mean it's not causing your skin rash. And we have multiple times patients with new onset skin rash, and I only hear about some of the over-the-counter things that they use, but they avoid anything natural or oils, essential oils that they use on their skin until I ask specifically, well, do you use essential oils or do you use, holistic things? Because they say, well, it's natural, so that's definitely not causing it. And it's not true. I think there's a lot of benefits we have from natural products and also benefits we have from synthetic products. And the most important thing for me is we do want to incorporate everything into your healthcare regimen. But just because it's natural, it doesn't mean it's safe, and it certainly doesn't mean it's not causing your skin reaction. And the reason why I like this infographic is because even when we talk about natural versus anything synthetic or medication-wise, there's always this balance of, well, what is it? Is it thought to be toxic, or could it potentially be hazardous? And then what amount of it actually makes it hazardous? And what is the frequency that we need to use it to create it? So for me, I think it's important that we want to keep natural products in our regimen, but I think we should all say, hey, just because it's natural, it's not safe. And what I like to tell my patients, particularly with essential oils, is that poison ivy is natural. You don't want it in an essential oil. And that's very similar. I mean, it's a plant. Plant-derived things can cause a lot of allergens. And the other thing that's natural, too, that we don't want to take is arsenic. So a couple of things just keep in mind when you say it's natural, it must be safe. So I think we've done our 20 facts in maybe just under 20 minutes. And so I'll look forward to some question and answers at the end of the session.
That was terrific, and I was amazed at how much I do not know, so that's great. Thank you. Our next speaker is Dr. Anna Gleisner, MD, PhD, who obtained her medical degree in Brazil, completed her residency at St. Louis University School of Medicine, and did a fellowship in complex surgical oncology at the University of Pittsburgh Medical Center. She is an assistant professor at Anschutz, and her specialty areas include biliary, gastrointestinal, and liver surgery. Her long-term goal is to improve the prognostication of patients with cancer to help guide treatment decisions. Thank you very much, Dr. Rice.
Thank you, everyone, for being here tonight. I'm going to talk about the liver, the gallbladder, and the pancreas. Those three organs are called the accessory organs of the digestive system, but as you'll see, it's really not justified. They are much more important than just accessories. So the liver is the human body's largest solid organ, and it's a gland. It's located on the right side of the body, and it rests below your right diaphragm. And it has two parts, one side, two sides, the right side and the left side. And then the liver is divided into different segments, 8 different segments, and 1,000 lobules. Each lobule is connected to small ducts, and this forms the biliary tree, which ultimately will connect to the common hepatic duct, which is a duct that brings the bile back to the intestine, so the bile can be dumped into the digestive system. The liver is very interesting in the sense that it has 2 different blood supplies. It has an arterial blood supply and a venous blood supply, and that is helpful for treatment decisions that we have to do. We can use the arterial supply of the liver to deliver medication without harming the liver, and we can cut the blood supply, the venous blood supply, to induce growth of the liver if we need to operate on the liver. And so we use that fact very efficiently in order to treat those patients that have liver issues. A lot of the blood flow goes through the liver. It has about 13% of the body's blood supply at any time goes through the liver, so it's a high volume, and that's why when people talk about liver surgery, it can be pretty bloody because we're going through a very vascularized organ. And the other interesting fact is that the liver regenerates. When we take a part of the liver, it grows again. It doesn't grow back like a tree, but it grows, it just gets bigger. Whatever we leave behind gets bigger in order to provide the needs of the human body. The regeneration happens actually quite fast. It happens in about a week. The full regeneration happens in 2 months, but the initial regeneration in a week is actually the main regeneration, and most of it happens that fast. So the liver is much more than an accessory, for sure. It has many, many, many functions. It produces bile. The bile is what it gets dumped into the digestive system, and that's used to absorb fat and to absorb the fat-soluble vitamins that we need, the A, D, E, and K vitamins. It absorbs and metabolizes bilirubin, which is a product of the red blood cells metabolism. And that's why you see when people have liver disease, they may become yellow. That's the bilirubin that's accumulating and not being taken care of and discarded by the liver. It metabolizes and stores carbohydrates, so has a role in keeping our blood sugar normal when we are fasting. And also stores some vitamins, produces albumin and many other proteins that we have, and creates cholesterol, which is also important, has immunological functions, and filters the blood. So when we drink alcohol, and many of the drugs that people take are metabolized in the liver, some of them in the kidney, but a lot of drugs that we take are metabolized in the liver. It breaks down proteins, so turns ammonia into urea, and then that's excreted afterwards by the kidney. And that's one important fact, because people that have liver disease will often accumulate the ammonia products, and that has many implications to their neurologic system. So liver disease, there are many types of things that can affect your liver. It can be genetic, or it can be caused by factors. So virus is one of the main factors. Chronic alcohol use is another factor, and drugs and obesity. There are some things we can do when we diagnose some of the viral diseases can be treated, some cannot be treated. And if the chronic exposure to some of those factors can lead to cirrhosis. And that what happens with cirrhosis is that the liver tissue becomes replaced by scar tissue, and it becomes hard, and no longer, the blood vessels no longer accommodate for that amount of blood that's circulating to the liver, and the liver also doesn't do many of the things that we talk about that it does, so it causes many issues. Some of the causes we talk about, so hepatitis B, hepatitis A, hepatitis C, some autoimmune diseases are also important. Liver cancer is another thing. The liver cancer can be primary liver cancer that arises in the liver cell, in the cells within the liver, or more commonly is cancer that arises somewhere else and then goes to the liver. The liver is one of the main organs for metastatic disease for many tumors. There's also non-alcoholic fatty liver disease, which is accumulation of fat within the liver cells, and that also can cause issues in long term, including cirrhosis. Now, in terms of women and men, the difference, women tend to be present with more acute liver failure, and that could be that women is a little more susceptible to alcohol. Autoimmune hepatitis, benign liver lesions are also more common in women, and some of them are related to estrogen. And primarily biliary cirrhosis, which is autoimmune disease, is also more common in women. So I don't think it really is an accessory. It shouldn't be called an accessory. It's such an important organ. It is, unlike other things that we have, we can do dialysis if your kidney fail. You can usually even walk around with an artificial heart. But the liver, there is nothing we can do. So when the liver loses its function, usually you have a few days to replace the liver with a new liver, and that's when people receive a liver transplant in the acute liver failure. The complications are vary around depending on the cause of the liver failure. If it's a very immediate liver failure that the liver just stops working right immediately, then a lot of the symptoms that we see is the jaundice, so the people becoming yellow, plus they can have a predisposition to bleed. If it's more of a chronic condition, it has more to do with the blood supply that goes through the liver and the backing up of those vessels that then instead of they need to go back to the heart somehow, so they find its way through vessels that are around the esophagus. So some of you may have read of people that they start having bloody vomit, they may vomit blood because those vessels rupture and cause that, and that can be a very serious complication. So how do we avoid liver issues? So we try to drink alcohol in moderation, and there is a difference in the recommendation for women and men here. The women should have up to 1 drink a day, and for men, 2 drinks a day. Vaccination for hepatitis A and B, avoid some risky behaviors, use some medication with care, and avoid contact with other people's blood and fluids, maintain a healthy weight. I think, still talking about what Dr. Newman said before, that there are some natural products that have been associated with acute liver failure. Some of the vitamins and things that were done in order to, they were considered natural, and they were natural, they end up causing patients to receive a liver transplant because of that. Going a little bit to the gallbladder is, I would say it's, in terms of function, is not that important, so it can be removed. So I think it's fair to call it an accessory organ. It's a small pouch, and it sits right in the liver, and what it does is just it stores the bile that's produced in the liver. And what it does is when we eat, there are hormones that trigger the gallbladder to contract and then to dump all that bilirubin, all that bile inside the small intestine, and that gets merged with the food, and that's how the fat gets absorbed. So it's not really essential. We remove a lot of gallbladders. The most common reason why we remove gallbladders is because of gallstones, and it's about 20 million people in the United States have gallstones. Not everybody has symptoms, and when people don't have any symptoms, and they just know about the gallstones, and they just found to have gallstones based on a test that was done for something else, we don't really need to treat this. But when they do have symptoms related to that, the treatment is to remove the gallbladder. And we do about 300,000 removals of the gallbladder every year in the United States. So it's a pretty common operation, probably one of the most common in general surgery. The gallbladder is not essential, but can cause a lot of trouble. So whenever there are stones in the gallbladder, they can cause chronic or acute inflammation of the gallbladder. If it's acute, it can perforate and can cause infections. They can also pass along the main bile duct and get stuck at the end of the bile duct and cause pancreatitis. It can cause infection, so a stone that's stuck in the bile duct can cause a very rapidly progressing infection that can be fatal. And it can also the gallbladder can develop cancer, which is a very, very aggressive form of cancer, the one that originates in the gallbladder. So risk factors for gallstones, being a female, so most of the gallstones happen in women. Being over the age of 40, there is some studies showing that the more kids you have, the higher your chance of having gallbladders, and that's because of estrogen has a role in the formation of gallstones. Mexican Americans and Native Americans have more gallstones, and so forth. There's some component of the diet, there is some family history, and having just chronic liver disease can also cause gallstones. Some medications with estrogen, also like oral contraceptives or just hormone therapy, can also cause gallstones. So for the most common thing that we see for when people have gallstones is symptomatic gallstones. So what people usually complain is pain in the right side of the body where the liver is, and the pain is usually triggered by food, and the food is usually either fatty food or spicy food, and it's about 30 minutes after that. So this is the most common presentation of gallstones. If the gallstones pass through the gallbladder and they get stuck in the common bile duct, then people can become jaundiced, so they can become yellow, just like when they have liver disease. But in this case, the liver is fine. It's just that the bile is not getting into the intestine, is backing up into the liver, and is making people yellow. The gallstones, if they don't have, so like I said before, if you don't have any symptoms, we don't need to do anything about it. We just watch it. And once we remove the gallbladder, most people have no problems. Some patients do have a chronic form of diarrhea when they eat fatty food, but most patients have absolutely no problems with that. So now a little bit about the pancreas. The pancreas is a gland, and it sits across in the back of the abdomen. It's behind the stomach, and it's the Y end of the pancreas. On the right side of the pancreas is called the head of the pancreas. The middle section is the neck of the pancreas, and then the left side of the pancreas is called the body of the pancreas, the tail of the pancreas. It is a very important organ as well. It has multiple functions. Just so people think about the pancreas, they think about pancreatic cancer, which is a very aggressive type of cancer, but a lot of people think about diabetes when they think about pancreas. But the pancreas has also exocrine function, so it produces a lot of the enzymes that we need to digest our food. So when people have surgery where we have to remove most or all of their pancreas, they have to receive some of those enzymes back. So the exocrine function, the glands produce those enzymes, and that's important to the digestion of a lot of foods a lot of parts of the food that we eat. So different enzymes digest proteins, carbohydrates, and fat. When the food enters the stomach, those cells release the pancreatic enzymes into the system of those small ducts. Very similar to the bile, there is this tree of ducts that form and then lead to this main duct that will actually join the bile duct and goes through the ampular vater, where the bile and the enzyme and all those enzymes are dumped into the small bowel. They enter the duodenum, and then again, it's important for the digestion of the fats, the carbohydrates, and the proteins. The endocrine function is the one that most people know about, and that's based on the different type of cells. So those cells are called the islet cells, and they produce and secrete hormones. There are insulin and glucagon plus other series of hormones that are not as common, but we see when people have disease, when those cells become cancer cells and they produce those hormones, they can have a series of symptoms that can be very classic of overproduction of some of those hormones that we don't usually talk about. The insulin, what it does is lowers your blood glucose levels. The glucagon raises the blood glucose levels and maintains the proper blood level, sugar levels for the function of the organs, including the brain, the liver, and the kidneys. So when we have some people, when the entire pancreas is no longer functioning, oftentimes due to surgery, one of the main problems is actually not the insulin that we can give, but is the lack of glucagon. And people can have pretty significant lowering of their blood glucose levels because it doesn't have the counteraction of the glucagon hormone. So it's a very important. Both hormones are very important. Some of the disorders of the pancreas. So the pancreas, it can cause diabetes, which is the main common thing. So if you don't have, there are two types of diabetes. One is type 1, which is an autoimmune disease, and the immune system destroys those beta cells, the islet cells in the pancreas, and there is no insulin production. The type 2 the body's liver cells and the fat and the muscle become unable to respond to the glucose. So the receptors that respond to glucose and trigger to the insulin and trigger the decrease of the glucose, they just become insensitive to that, and that's why the insulin levels are actually high, but the glucose levels are also increased. Pancreatitis, it can be a fatal disease. It can cause all those digestive enzymes can be released in the pancreas, around the pancreas, and all of around the tissues that are around the pancreas, and this autodigestion can happen and cause infection and other issues that can be deadly in a significant number of patients. Chronic pancreatitis is more a chronic disease when the pancreas, there is some degree of obstruction of the main pancreatic duct, and the gland becomes atrophic, and it long-term, it doesn't function as well. Pancreatic cancer is one of the most feared cancers. It can happen at any age, but usually in patients that are older than 60 years old. There is some association with smoking and heavy drinking, but a lot of patients have pancreatic cancer without having any of those exposures. The symptoms appear usually when patients have a more advanced disease, so the treatment can only be done, which is surgical resection, can only be done in a small proportion of those patients. And the classic presentation is, again, it's because the bile duct is going right through the pancreas, it's jaundice. So again, patients become yellow, and it's because of that duct that comes from the liver and dumps the bile into the intestine, being obstructed by the cancer. So the treatment, when we have pancreatic either insufficiency due to both types of cells in the pancreas, the treatment is insulin injection. For pancreatic cancer is resection, so it's surgical resection plus chemotherapy. And then finally, if you have a problem with the enzymes, deficiency of enzymes, patients can receive enzymes, and that has to be done on a daily basis every time they have a meal. The failure of those enzymes will cause chronic diarrhea, malnutrition, and weight loss. It's the classic presentation of patients that they notice that when they go to the bathroom, their stool floats. That's because of the fat content of the stool is high, and that's how they get a clue that there is something going on. And they, despite eating a lot, they just don't gain any weight, and they start losing weight because the food is not being digested, it's not being absorbed like it should. With the endocrine failure, there is inability to control the blood glucose levels, and then we need to use insulin, and the chronic increase in the blood glucose levels can cause a lot of chronic problems in the eyes, kidneys, and other areas of the body. So it has to be replaced. Thank you.
Thank you, Dr. Gleisner. It's terrific. Our last speaker tonight is Dr. Eve Berger, who is just a blockbuster. Dr. Berger is one of the few women chairs in departments of surgery, orthopedic surgery in the country and probably in the world. How many are there worldwide? One. Okay, well, that's rare. And we are very lucky to have her here. In 2006, she joined the University of Colorado Department of Orthopedics, where she founded the Adult Spine Unit. She came from South Africa, where she did military service, and it was just amazing work. She has won numerous awards for her research and has received international recognition for her work. After serving in various leadership positions in the department, she not only became the chair of orthopedic surgery, but also the first recipient of the Robert D. Ambrosia Endowed Chair in Orthopedics. Thank you, Dr. Berger.
Thank you very much. Well, thank you very much for coming on a cold winter's night. And I do want to thank Dr. Regensteiner, Judy, as a dear friend, and her passion to point out the inequalities in healthcare for women has led to this amazing organization. So you are truly an icon. You've established this Women's Health Forum, and I'm humbled to be part of it and to be asked to be here tonight. So let's put our hands together for Judy. So I decided to talk to you tonight about back pain. This is what I do on a daily basis. So the spine consists of vertebral bodies, discs, and that is basically the housing for the spinal cord. We have nerves that are myelinated. That means that it's not part of your brain that's jello. Your brain is actually jello. It's actually a nerve that you can see. And you also have to remember that your spine, even though you feel it at the back, is in the middle of your body. If our spines were really at our backs, we would be quadrupedal. So when you stand up straight and you hold your back, you must remember your spine, the actual bones, sit in the middle of your body. And that's the only way we can be upright, and that gives us our unique curves, and that comes with its own set of problems that we'll talk about tonight. The most important function of the spine is that it is the flagpole that carries your body, but it's also our shock absorber. The discs in between are unique. They limit us so that we don't do so much motion that we dislocate our spines. That gives us the shock absorber so that we can sit all day. So trivia question, from standing, sitting, lying, and walking, what puts the most stress on your spine? Sitting. So in the old days, we used to say, oh, this patient's disabled, give him a sedentary job. It was the worst thing we could do, okay? So this is a nice picture of a disc, and you can see that the disc has all little arteries that supplies it with blood supply and nutrients. It has this thick outer layer, and then the inner side, that's the gel. And so this is a nice, healthy, cushy disc. Now, in different stages in our life, we can all have back pain. But a child with back pain is definitely different from your grandmother that has back pain. So when you're a newborn, the things that affect your back is congenital abnormalities like spina bifida, where you're born with an open canal, and that's usually associated with a folate deficit, as we know from big communities in England. You can have infections. Little babies can get Staph aureus, Haemophilus influenza, or Klebsiella kinkei is the new organism, and these three are responsible for almost 99% of all infections that we get in babies in their spine. Children, again, the biggest cause for back pain here is infection, actually discitis. We can get an abacterial discitis, so that's the disc. There's the vertebrae, and there's the disc. You can see over here, it's really narrow because there was an infection here. The bone has reacted it, and it's not nice and juicy. We can also get tumors in children. You can have juvenile onset scoliosis before the age of 10, and then dysplastic spondylolisthesis. In adolescence, the patients present with back pain, and they have small tumors like osteoid osteomas, osteoblastomas, which are benign tumors but cause significant back pain, difficult to diagnose. They can have Scheuermann's kyphosis, and this is your teenage boy that sits slumped like that. It's sometimes not because they want to sit like this. And I remember how my grandma would say, sit up straight. And sometimes they can't sit up straight. And then they can have a slippage of one vertebrae over the other. Like over here, you can see vertebrae coming down and then sliding over the other one with a big disc in the canal. So idiopathic scoliosis, another disease that we see more expressed in females. And so it's 90% prevalent in girls. So much so that if we get a scoliosis in a boy, we actually approach it a little bit different and doing MRIs where we do not just accept that this is idiopathic scoliosis. Young adults, this is our invincible youth, okay? The ones that drive down the highway without a helmet. They can actually get disc herniations. They can also get the spondylolisthesis, that the one slips and then fractures because of their risque lifestyle. So this is an example of a spondylolisthesis. Very common, that's a spondylolysis. We see this in rotational sports. So you see it in high-grade soccer players where they run and they stop and this kicking leg comes and they rotate over. So we also see it in our baseball players because of the way that they rotate, and it's a stress fracture. Disc herniation, this is what it looks like on an MRI. You can see here's the canal, and then there's this big honking black thing in there. That's a disc herniation, okay? So I want to point out now that disc herniation is not aging. There's a huge difference. Herniated discs are associated with a spontaneous increase in the production of osteoprotegrin, interleukin-1, receptor activator rank, ligand, and parathyroid hormones. So we don't know. People come to me and then I say, you've herniated your disc, and they ask me why. And I usually tell them, you should have picked your parents better. Because there's definitely a genetic trend for that. But we also have, through research, determined that there's a definitive inflammatory process. Something happens that makes that disc vulnerable, that wants to pop out like a zert, okay? So when we age, our discs lose water. We talked about water and hydration tonight. And so from that nice soft gel, it becomes fibrocartilage, which is like your earlobe. And there's a lack of nutritional transport, and the viable cells goes down, and the pH changes, and there's an increase in keratin sulfate, which is what makes your nails strong, and there's lactate in, so it becomes acidic, and it's just a mess, okay? Here is an example of a patient with a disc herniation. This is the bones, that's the discs, and here you can see the disc is bulging out. So that disc either got severely injured, or with a spontaneous herniation, something happened and the pressure built up and the disc lost its integrity and then decided to herniate out, okay? So when we get into the Middle Ages, we suffer from disc degeneration, we can have disc herniation, and everything that has happened to us in our childhoods, the kyphosis, the infections, the herniations, actually now progresses, and you start on the downhill spiral. When you are older, you can still have disc degeneration, but now all of these things that happen, the aging is now given a fancy name called spondylosis, and actually that just means you've got a crappy spine. But that's the way that we can bill for it, okay? So you can see, your disc becomes all dried up. It gets full of cracks. It doesn't absorb the shock. There's a huge inflammation, and all of these ligaments becomes hard, and look what happened. The space for the dural canal lessens, and this is known as stenosis. So the saga continues. Look at the lovely spines we saw earlier. Now look at this. This is an aged spine. There's no disc space. All of these spurs are growing out. The joints that were supposed to be nice has now got spikes. It looks like you're spelunking in here. And then somewhere in there, there's a little hole for a nerve to come out, okay? Now we look at the geriatric spines. There's one thing that changes dramatically. We now not only get degeneration of our discs, but now our bone gets weak and we get the famous osteoporosis. And we get compression fractures that actually increases to our forward bending. When an older patient comes to you with a spontaneous onset of back pain, you have to always think metastatic disease. Unfortunately, cancers love to go to the spine because it's got a big blood supply, it's vascular, so they can grow and proliferate for a long time before we discover it. And patients will present to the ED, and grandma will say, well, I've had some back pain, and then you go into her previous history. Any other diseases? No, absolutely nothing. Any other diseases? No, absolutely nothing. And I usually tell my students this is how it goes. Patient comes in, oh, doctor, my back is hurting so bad. And then you say, so when did this start? Oh, you know, at my doctor's wedding. Oh, not a beautiful wedding. You should have seen the flowers. You should have seen a dress. By the time you get through all of this, you go like, so tell me a little bit more. No, I picked up the flowers. Okay, yeah, this is not right. This age group should not get a disc herniation because everything is already hardened, so it won't pop out. And then I said, do you have any other diseases? No, absolutely nothing. Then you examine the patient, and then you say, oh, I see that you've had mastectomies. Yes, that was 20 years ago. I'm cured from my cancer. So it's very hard because people consider it that they cured. And for us as clinicians, we always have to keep in the back of our mind metastatic disease and myeloma, other diseases of the bone marrow itself, like myeloma, mastocytosis, lymphoma, leukemia. All of these diseases of blood marrow loves to live in the bones. So lots of traps for us when we look at back pain. So what's the natural history of the aging spine? You get spinal stenosis, so there's a reduction in the space where the nerves has to run here. And this is caused by the joints that are now getting arthritic. Look at it looks like candle wax. So the body wants to stop it, so it thickens this ligament. It looks like an upside down mustache. The disc is herniated, and this space where the nerves have to run, this little nerves, is not big and round. It's now compressed through a triangular space. So what happens? We get height loss. The annulus, that outer layer of the disc that encases the soft part, has collagen type 1, and that's usually obliquely oriented. And to explain that better, it's like radial steel tires. If you have radial steel tires, you can go around the corner at a fast speed, and the way that the fibers of your tire interlocks, when you put more pressure on, it interlocks a little bit more, and it keeps the stability. When we get old, our radial tires get like Swiss cheese. Okay? And now it's infiltrated with fibroblasts, which is scar tissue, and we don't have our normal heights. The nucleus, which is the gel on the inside, mainly has type 2 collagen. It's very rich in water. This is what gives us the chewing gum consistency. It has low collagen, and it has cartilage type cells, and it produces collagen type 2. So degenerative disc disease definition, it is a degenerative aging process affecting all levels of the spine, resulting in alteration or impairment of the morphology and the function of one or more spinal motion segments. It's caused by genetic factors. There was a large gene population found in Hong Kong Chinese people for disc degeneration. Heavy lifting, twisting. Our golfers are all prone to this. Cigarette smoking, it hardens up your disc just like it hardens up your lungs. And I tell all my smoker patients, I don't care about your lungs. I'm an orthopedic surgeon. They can transplant that, but I can't transplant your spine. So you better stop smoking, okay? It causes hardening of the arteries, arteriosclerosis, so there's no blood supply to the spine and the discs. And we also see it in some occupations like truck drivers. We also see it in people that work with jackhammers. You can imagine if for every day, 10 times a day, you're doing this on your spine, that there are some mechanical factors that will wear out your spine. So this is an example of a beautiful newborn. And this is the disc, and you can see the glistening gel and the outer fiber layers. And then this is an adult. You can see the glistening is gone. We don't sparkle that much. There's little pitting here and there, little wear and tear. We need some retreads. And then we get a little bit more older, and now there's nothing shiny about us. It's all hard cartilage. And then finally, we get like grandmother, and the disc is actually totally destroyed. It's infiltrated by different toxins, and it looks like your lungs. It's bad when you have this. The joints at the back here, you can see they look like hip joints, but they're actually supposed to be in your spine. because they're trying to maintain the stability because the disc is not working, so they get bigger and bigger and bigger. And that actually contributes to the stenosis. So this is the space where your nerves and your spinal cord has to run. And you can see, if I just flip back to this baby, look at this nice big space. And this is grandma, okay? So the problem with spinal diseases, it will be back, always. When you get older, it's, oh, my back, okay? So we get the disc degeneration, we get the vertebral compressions. So vertebral compression fractures are most common fragility fracture. There are more than 700,000 compression fractures in the spine every year in the US. Osteoporosis was designated by the Central Health System this year as the biggest silent killer and causes of the biggest morbidity in our population. Because our population is aging, people are not aware of this, and about 50% of patients will die within 18 months of their first osteoporotic fracture. So it is a killer, okay? It costs us billions a year, every year, because patients, you don't only fracture your spine, become disabled, sit in a wheelchair, you also fracture your hips, you don't walk, and if you don't walk, you don't have good aerobic metabolism, downward spiral. Okay. 25% of people over the age of 70 is affected by osteoporosis, and half of the population over 80. The risk factors, if you've had a history of 2 previous compression fractures, that's probably the strongest predictor of having another one. You must remember in osteoporosis, your bone is of a normal quality, but it is flimsy, it's decreased in quantity. Your cortex, the outer layer of the bone, is extremely thin, and the trabecular bone, that's the mushy bone on the inside, is really decreased. So your bone mineral density is at its best between 33 and 40. And after that, it starts to diminish by almost 2% per year. It's critical that we get our youth walking. We have no idea what is going to happen to our youth that sits day after day after day behind their iPads, their TVs, their computers, or whatever. Because you build up your bone till you're about 25, and then you can add a little bit by impedance, exercising, and good diet. But after the age of 40, you can do very little to increase your bone density, and what you have is what you have. So it is critical if you have children or family or whatever. I don't care if they think you're the nasty aunt, just get them out and get them walking, okay? So the aging spine has both the osteoporosis, it has the arthritis, which is all the disc degeneration, and the degeneration of the discs. So it has 3 components when you're older. Osteoporosis, as I said, is age-related. The osteoarthritis is those joints that get bigger and bigger as it tries to stabilize your spine. And then the disc that we described very well tonight, that loses all of its water content and it becomes really hard. I'm sorry I forgot to bring some Kleenex because this is an abysmal picture. Okay. So the end result is we lose height, we lose our ability to stand up straight, we become shorter because our vertebrae compresses and our discs degenerate, and you can lose up to 6 inches through this process of aging. The motion segment that we refer to is 2 vertebrae and the disc in between. That's a motion segment. So this is the disc that we spoke about. This is the vertebrae that gets osteoporotic. These are the joints. They are like locks at the back. And you can see here they get arthritic because that's the only thing that keeps this space open where the nerve runs out when the disc collapses. This is an example of a patient that had all of this. She got disc degeneration, she collapsed, she got arthritis, she had scoliosis. Somebody tried to do something at the back, so she came to us, and you can see that her head is way far forward. She cannot walk without the help of a cane. And I always see this, they have a neck surgery. Because what happens, if you can't walk and you're walking forward, and you can't see, you do this. So the first thing that happens is you degenerate your disc in your neck. And then that's the first thing that gets fixed. And people do not recognize that this is part of a global picture. So it's a cascading event unless you can get the patient back to balance. So this disease is appropriately treated, not with this or that, but by actually reconstructing the whole spine. Keeps the patient upright, keeps the height, fuses all of the segments. As big a surgery as this is, patients are much more functional because they can stand up after this and have a normal stride length. Something I want to put in here, and that is MRI and CT findings must be correlated by history, physical exam, and physiologic testing. I cannot tell you how many times people will find me and say, "Hey, would you be so kind and take a look at my aunt's MRI?" And I said, yes, because I'm courteous. But it means absolutely nothing. Because if I take 100 people in the street and we do an MRI of them, 20% of those MRIs will be abnormal, and none of these patients would even have an iota of back pain. So the MRI is to confirm the diagnosis. We treat patients, we do not treat MRIs. And it's something that people get angry at. I've had back pain for a year, my doctor doesn't want to order an MRI. There are specific indications for MRIs and CT scans, and 90% of an episode of back pain will go away with no treatment. So please stay away from the doctor, okay? When we see the patient, we take a thorough history. You ask about that wedding and the heavy flowers and the breast cancer. You have to examine the spine and get an idea of the patient's global picture. What range of motion do they have? What nerve fallout do they have? Which muscles are weak, if any? And I can also tell you that 80% of the time you don't find anything, but there are subtle findings. And then you look at the MRI and go like, I see she can't pick up her right toe, big toe. So that I know is the L5 dermatome. And then I go look at the MRI and see if there's anything pushing on the L5 nerve root. If I look at the MRI first, I'll see, well, there's a massive disc at L2-3. And then it doesn't mean anything. She had the disc, but it's not bothering her because it's not pushing on a nerve. So please don't treat the MRIs. Don't let anybody tell you, oh, I've looked at your MRI, you got a big disc, you're going to be paralyzed, because that's a bunch of BS, okay? The red flags that we look for when a patient walks in and they have constant pain, they can't sit in the chair. You ask them, did you take some ibuprofen, Tylenol, anything? No, it doesn't help. The pain is there day and night. It's not alleviated by anything. They've lost some weight. You know, doctor, I thought I was really hot last night. Or, I know it was 70 degrees outside, but I felt really chilly. I just don't feel good. I'm tired. Those are the red flags. Pain that does not go away when you lie down. Almost all of your back pain, people who have back pain will feel better when they lie down because they unload their spine. If a patient tells you, I can't lie in bed because my pain is so bad, that's a big red flag. And the back of your mind should go, serious disease, most likely a tumor. We do basic blood works, look at the calcium levels, look if they have liver disease, so I can ask Anna to replace the liver. I can't replace the spine. We look at their white cell counts to rule out infections. We look at the sedimentation rate, which gives us an idea if the patient is sick or not, and the C-reactive protein. These are screening tests. It tells me whether a patient is sick or not, okay? So how do we prevent this terrible cascade? I'm sorry that I'm so abysmal. We have to get out, we have to walk, we have to do impedance exercise. If you can just walk 3 times a week for half an hour, you've done yourself more good than any supplement that you can take. You have to walk. You have to be agile. You have to stay loose. You have to stay fit. You have to do good core exercises. You have to tone up your muscles. Because as you can see, the spine is going to age. The only thing you have is your muscles. The spine is the flagpole. You got to work on the flag, okay? Do core strengthening. Do weight training. Eat a protein-rich diet. You can drink all the calcium in the world. You're going to get kidney stones, and it's going to go in your urine, okay? It doesn't help. You need a lattice work, and the lattice work on bone is only filled by protein. I had an old mentor who said to me that when I was a medical student, the picture for us was painted. And he was one of those old ones, do this. And he says, so all of you medical students sitting here in front of me, you're going to work hard. And then one day you're going to stuff your parents in an old age home. And then your dad's going to die. And then you're not going to see your mom because you'll be too busy driving your sports car. And then you're going to feel guilty and you're going to buy her a Persian carpet and a cat. He says, and then she's going to give all the milk to the cat. She's going to drink a gin and tonic because she's depressed. And she's going to fall on the carpet and break her hip. And that's the picture of osteoporosis. So I hope that I've put the picture in your head of what is osteoporosis. And with that, I want to say, stay young, stay healthy, stay fit, and thank you very much for listening.
Those were three wonderful talks by three spectacular speakers tonight, and I really appreciate it. I want to have another round of applause for our speakers. I'm going to ask you all to come over here, and we're going to hold a panel and let everybody ask the questions they want to ask.
Sure. Yeah, so the question is about SPF levels and what is the ideal SPF level. So for some time now, actually, in a few years, you won't see 100. They're actually going to top it off at 50. The way sunscreen works is it's sort of a bell curve. So at about 50, you really don't get much more benefit once you get above that. And sometimes we also feel that that SPF of 100 gives you a little bit of false confidence. And all of us, none of us put enough sunscreen on. But SPF of 50 is just fine, particularly if you're going to be outdoors. For daily here in Colorado, an SPF of 30. So there is a difference between 30 and 50. It is small, but it's still significant. So outdoors 50, daily 30.
That's a big topic. So there are different mechanisms for treating osteoporosis. Some of the drugs like Fosamax is a biphosphonate gets incorporated in the bone, and it makes the bone harder but brittle. And there are good reports that if you use it for longer than 2 years, it is associated with spontaneous fractures. Your bone actually replaces itself every 24 months, completely remodels itself. Because if our bone was dead and wouldn't remodel, it won't last. So the bone is very much alive. Some of the newer drugs actually confuses the bone. So it doesn't see the cells that eats up the bone. It blocks it, so it doesn't see that. And the advantage of those drugs is that once you stop taking the drug, the bone comes back to its natural state. We are very blessed to have recruited the world's top leader in osteoporosis, Dr. Cheryl Ackert-Bicknell, and I will have Judy have her here next year. And she has just published in Nature, and she has identified 300 different genes in osteoporosis. So this is a much bigger disease. We are treating the printer, and the problem lies in the computer. I hope that helps you.
People are having trouble hearing. Is this working? You got to talk right into it. Sorry.
So are you talking about self-tanners? Yes, there's a lot of self-tanners out there now, and they are considered safe. They actually are very high up in our flaky layer of skin, and that's the only place they stay, which is why they typically only last about 7 days. And so there's a lot out there. I wouldn't say that there's one in particular that I would recommend. The spray tans are also safe. One thing with spray tans is they're often within a tanning salon. And they try and sell you on the tanning salon. And so that's just one caveat. So I do like a lot of the over-the-counter moisturizers that have a little bit of the tanning in it. Actually, is a little bit easier to manage, and you don't get very streaky. So you typically use it about 5 to 7 days before you want to look like you have a tan, and that will be efficient, and you don't tend to get streaky.
Dr. Berger, what would you say about reclassed?
Reclast blocks the osteoclasts. So we have two types of cells in the bone. We have osteoblasts and osteoclasts. The treatment, when you use reclast, it blocks the osteoclast. So the clast is the munchy cell that eats up the bone and eats up the dead bone. And when you use reclast, it blocks that cell so it doesn't eat up the dead bone. It's important that the dead bone be eaten up because it produces calcium to form a new bone. But if you're osteoporotic, you want to slow that process down, and that's how reclast works. So it stops the active degradation of your bone, but it's not a bone builder.
I have a quick question for Dr. Gleisner. I hear about more and more people surviving with pancreatic cancer. To what do you attribute this?
Some of it is some perioperative changes in the perioperative care of those patients. So it was a surgery that up to the 80s had a mortality rate in the 20%. Now the mortality rate for removal of the head of the pancreas is in the 1 to 2% range. Some places like our hospital have very low mortality rates. It's much safer. So that was one of the things. And the second thing is better chemotherapy. So systemic treatment the main problem with pancreatic cancer is that it's so aggressive that by the time of diagnosis, people have disease in the liver and the lungs. They don't know yet because it's microscopic disease, so they just don't know of the disease. And the current chemotherapy agents are more effective at killing what we call the micrometastatic disease, which is just a disease that's there, but it cannot be seen by the common imaging that we have. So that's the main reason, two main reasons.
Oh, I'm here. This is also for Dr. Gleisner. What progress has been made on artificial pancreas for diabetics?
Mostly is isolation of the islet cells and injection in the islet cells, but there is not, the results are somewhat good, but still not very applicable everywhere. So there is some progress, but still not great progress. And I think because all the medication, the insulin is becoming, although it's really expensive, but it just, the way that it's easier, it controls the glucose levels better. So to isolate the pancreas cells and inject the pancreas cells and then have that not take, it may be too much for if you can have a normal life with the insulin, all sorts of different insulins that we have. Pancreas transplant is one thing that has been done for many years. It's also an option. The problem with pancreas transplant is you have to take the immunosuppressant drug, so they decrease the immune system so that your body doesn't reject the pancreas. And that has a lot of issues long term with the immunosuppressant. So that all has to be balanced against the fact that you can have a healthy life with all the insulin products and some dietary modifications. The pancreas transplant is most often done at the same time as kidney transplant because then you're already taking the medication for your kidney, so you're not taking for the pancreas alone. Some people do get, if they have very bad diabetes, they may opt for a pancreas transplant, but it has some complications, and the main issue really is immunosuppression, is the drugs to decrease your capacity to fight infections, so you don't fight the organ that you're receiving that someone else's.
What are your thoughts about keto and high protein diets and their effect on our liver and pancreas?
I find all the diet recommendations such a mess, right? It's just so hard to know what works and what doesn't work. Some people have really good results with the diet, but there is definitely increase in accumulation of fat in the liver if you eat a lot of a diet that's rich in animal fat. So I would say that for short-term weight loss, it's probably appropriate, but I wouldn't do it as a lifelong commitment to it because it can induce steatohepatitis instead of just accumulation of fat, just fatty liver in general because of the amount of protein, animal fat. And animal fat has other implications associated with increase in the risk of colon cancer and breast cancer. So that's another reason not to stay away from high amounts of protein, of animal-derived protein. I think that diet is just so complicated. It's just there's so many studies out there and they contradict each other all the time. It's very hard because people that eat a healthy diet also usually do other healthy things. So to prove that this is really based on the diet is really tough. And there's just many studies out there in the diet talking about butter. So first we shouldn't eat more butter. Now we should eat butter again. And it's like it goes up back and forth. And I think what I tell people when they ask me about their diet, I say just a healthy diet. What's a healthy diet? Nothing in excess, right? You can eat a little bit of meat, but just don't eat steak every single day of your life, right? You should definitely eat vegetables and legumes and those things that are known to be protective for cancer as well. But it's just that it's a tough science because the data is just so hard to interpret. Yeah.
That's a very interesting question because the one part of the spine that I didn't address tonight is our muscles. And that seems to get neglected in the lieu of the bone and the discs that we can see better. When you take a muscle and you stretch it, say for instance, somebody pulls on your arm. At a certain point, there's a viscoelastic property of that muscle. The muscle relaxes because you're stretching it, and then at a certain point, you get a rebound spasm. So this happens with inversion tables. People get immediate relief when they lie on it, but after a month, they'll tell you it doesn't work anymore.
Dr. Berger, is there any information about your height having an impact on your chances of having more or less back pain throughout your life? Like if you're taller, you're going to have a longer lever. Are you going to have more challenges keeping it aligned?
I can see that you're tall.
Yes.
Yeah, so the world was unfortunately created for midgets. And if one of the things that you do every day that puts a huge amount of stress on your back is brushing your teeth. Just think about that. You stand in front of your sink, and then without supporting you, you're bending at a maybe 35, sometimes 50 degree, and then you go down to 90 degrees to rinse your mouth, okay? No support, then you come back. And most of our sinks are very low because it's not made for tall people. So the way that you need to protect your back is whenever you want to bend forward, and I stand in the OR for multiple hours, you have a little bench, and you stand with your one foot up like this. Oops. Like this. And then you can bend forward because now your pelvis is actually blocking you versus if you stand like this and this. The moment you put one foot a little higher, your pelvis stabilizes and then you can use your hips better. And if your hamstrings are short, you also bend with your discs much more. So yes, it is the ergonomics of getting general back pain is very important. That's what we look in industry. That's why we have standing tables now and not just sitting. And the specialty that works on this is occupational therapists. They can come out to your house and look at these things or at the workplace and make it more ergonomic.
I have a question for Dr. Newman real quickly. Dr. Newman, it seems, did you not say that skin cancers are on the rise? With all the knowledge that we have about preventing skin cancers, why do you think that's happening?
So it's slightly going down now, but the big rise initially is just our aging population. Folks are getting older, living longer, and have more cumulative sun and sun damage, and that increases risk for skin cancer. The good thing is, as I mentioned, there is, over the last 10 years, a slight decrease in young women actually developing skin cancers, particularly melanoma, which is actually is really great.
Dr. Berger, I wanted to thank you so much for highlighting the significance of correlating the clinical findings with the MRI. As a physical therapist, I spend a lot of time talking to people about the wedding, the flowers, and the MRI. And so that extends the length of time, so I appreciate that. That's really important. But I have an SPF question. I was wondering, does the number on SPF correlate to the length of time that it's effective? So 30 means 30 minutes?
Oh, sure. So yeah, let me go over how SPF works. So the SPF, if it's an SPF of 30, it means that you can stay outdoors 30 times longer than you normally could before getting red. So it's a little bit complicated because it all depends on your skin type. So the fairer you are, the less you can stay out. And we call it's a minimal erythema dose. That's kind of our technical term for it. So we're all a little bit different. But basically it means that number says how long beyond your redness. Now, we all don't know how long it takes us to get red. So the more important thing I would say with sunscreen is that just needs to be reapplied every 2 hours, particularly if you're sweating or swimming. But really, sunscreen wanes after 2 hours. So it really should be applied every 2 hours.
I'm not sure, is that on? But Dr. Berger, you mentioned yoga, and for those of us that do yoga or Pilates and have osteopenia, is there anything to be concerned about with twisting or bending or certain poses that would aggravate things in the back, or is it generally, if you're focusing on your core, it's good to do those kinds of exercises?
That's a very interesting question. I do Pilates myself. I wish I was more did it more, because it's probably one of the best exercises that we can do that does not specifically have an impact on our spines or on our knee joints or hip joints, and it gives you great strengthening of your muscles, and it keeps you limber. So my general advice is that everybody is a little different. And everybody has a different pathology in their back. If you are doing an exercise and it feels uncomfortable, stop. Because don't try to be the poster girl during that session, because that's when you will actually just go beyond the physiological norm of your specific back and then cause that first critical injury to a disc. So whenever I get there, the lady said to me the other day, "Have you ever done this before?" And I go like, "Yeah, right," because I wasn't very good at it, but I didn't feel like I wanted to do all of the stuff that she wanted me to do. So that's my best general advice. Don't do anything that feels uncomfortable. Don't push it. We don't. So isometric exercises in general is good. That means when you don't take both your legs and jackknife it up. The worst we do to our military people is to have them do sit-ups. But if you do an isometric, so left hand up and right leg up, that's oblique. We have a lot of muscles that works oblique. But when you do a jackknife or something like that, that really puts a huge amount of strain. That initiation of that movement puts unbelievable square pound per inch pressure on your disc.
Well, thank you all very much. That was wonderful. I would ask all of you to fill out your surveys that you will receive online, and we really appreciate it, and it helps us to get feedback. We want your ideas for future programs. Our next program will take place in February, probably towards the end of February, and we'll be sending out the word on that. It will probably focus on the heart, given that it's February. I want to thank you again for coming. We love it that people come, and we love providing evidence-based information for you. Thanks again, and have a very good night.